On average, in the United States, one suicide occurs every 17 minutes. South Dakota ranks 9th for the rate of suicide, and suicide is the second leading cause of death among college students. We look at suicide and suicide prevention tonight. The doctors are on call now.
Funding for this program is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
Simply put, suicide is a terrible topic and risky to discuss as it might offend or hurt people who have been affected by it. Yet we are compelled to address this painful issue since over 1 million people die from suicide every year, and it is the 6th leading cause of death in the United States. What's most frightening to me is that suicide is one of the leading causes of death in teenagers and adults under 35 years of age. It is interesting to note that men are 3 to 4 times more likely to kill themselves than women, although women are twice as likely to attempt suicide as men. And the single most at-risk individual for suicide is an elderly man who has recently lost his wife. Jewish, Christian, and Muslim traditions believe in the sanctity of life and that suicide is an act against God. That sociologic belief was so strong that at one time in England there was a law against suicide, punishable by, you guessed it, the death sentence. A real story explains the paradox. In the mid-1800s, a fellow apparently cut his throat and windpipe in an unsuccessful attempt at suicide. They found him in time, saved him, and then hung him to punish him. When the rope tightened, his windpipe opened up below the noose, and they had to struggle to finally finish him off. This topic is broad, to include euthanasia, where individuals ask for help to end their lives, murder-suicide, mass suicide, acts of terrorism, and suicide bombing, as well as the heartbreaking suicide stories we all have experienced. To help us deal with suicide and to explore ways to prevent, we have a guest for tonight. Matt Stanley, a psychiatrist and director of Avera Behavioral Health Center, who practices at Avera Medical Group, University Psychiatry Associates in Sioux Falls, joins us. Thanks, Matt. Kind of a tough topic. I appreciate you coming. I know this was a tough thing. You had a death in your family. You made an effort to be there, and then you made an effort to get back to our studio. Thank you for doing that.
Absolutely. It's an important topic, so I'm very glad to be here.
So tell us a little bit about you. Where are you from? How did you get here?
Well, I'm actually a South Dakota State grad. That's how I ended up in this area. I'm from Southwest Iowa originally, but met my wife here. She's a South Dakota native and went away for medical school. Was at UMKC for my first year of residency, and then my wife became pregnant with twins, and we decided we wanted to raise our family here. So came back here to finish residency, and we've been here ever since.
Oh, so you have twins? I didn't know.
I have twin daughters at the University of Arizona, and 2 still in high school.
Oh, so and you were at SDSU. You were a football player, is that right?
That's right. That's
Award
how
winner.
I ended up here.
Yeah, you were you played backfield or
linebacker.
Linebacker and defense.
Yeah.
So, well, we're glad you're a psychiatrist now. Do you think that football experience helped you train for psychiatry?
I don't know. I've often wondered if I'm the only former linebacker psychiatrist in the country, but I think what it did do is taught me team interaction. So I like working in a group, looking at systems, and just taking a systemic approach at change. So.
I know you're doing a lot with the behavioral health system. You're the leader of what's your exact position?
Well, I'm, as you said, the medical director of Avera McKinnon Behavioral Health Center, but we're making a service line initiative. Avera's 5 regional hospitals, along with a number of clinics affiliated with those different regions, and behavioral health is one of the areas that we have a very strong presence in and a very strong reputation. What we're doing is, and I know you've been involved in some of that discussion, we're just kind of coordinating our efforts across all the regions. Our catchphrase has been, the whole should be greater than the sum of the parts. We need to gather our resources, create evidence-based medicine approaches to treatment, and really just tighten up our system to make sure it provides the best care across this entire region that's possible.
You know, the behavioral center that we have in Sioux Falls is beautiful, and there's nothing quite like it for many, many miles. I mean,
actually, we've been told it's unique across the country, and we were told by Mark Covell, who's the president of the National Association of Psychiatric Hospitals. It's brand new, as you know. It's a beautiful setting, and we created it with the idea that there should be no stigma with mental health. But under one roof, we have a psychiatry residency, child fellowship. We have a pharmacy residency in association with SDSU. We have the Avera Institute for Human Behavioral Genetics, which is, we think, a unique entity in that it's a genetic research lab dedicated to the idea of behavioral genetics, along with the fact that we have as you said, a 110-bed dedicated psychiatric hospital. We have ECT. By the way, we're adding transcranial magnetic stimulation in the very near future. So another cutting-edge treatment that will be available in Sioux Falls.
Explain ECT.
ECT, electroconvulsive therapy. It's been around since the 1930s.
Got a bad rap with One Flew Over the
Yeah, that among other things. But ECT has come a long way. Obviously, the portrayal in One Flew Over the Cuckoo's Nest is not very accurate. However, I will say this, that over the last 20 or 30 years, all of the changes in ECT have been, some have been to increase effectiveness, but most have been to make the treatment as tolerable as possible. So physically and physiologically easily tolerated. You don't come out with sore muscles or broken bones. We use medications to relax the muscles, the patient's fully anesthetized, but also in how we deliver the stimulus, the electrical stimulus, everything from the brevity of the electrical pulse to the waveform of the electricity, all those things have been researched and much improvement has occurred.
Now, you discussed electromagnetic resonance.
Transcranial magnetic stimulation.
Now, I have read about that. I think it was in the New England Journal. Could have been JAMA. But the question I have is, what the heck is that? I mean, we all take... we order magnetic resonance
MRI,
imaging.
for instance, is a form of magnetic resonance. But when you bring two strong magnetic fields together, they create a focal point.
Right.
And the idea is that you can aim that focal point within the brain and affect that area, much like ECT. To some degree, there's a commonality there, but far more focused and without the generalized. In ECT, what we do is induce a seizure, and that seizure generalizes through the whole brain.
Right.
With transcranial magnetic stimulation, the patient is awake the entire time. In fact, we'll be talking to a tech or the physician, whoever's in the room with them, but we target specific areas of the brain. And in fact, when we tune in the TMS, when we move it across the brain to make it in the right place, we can actually make muscles of the hand move as we move across the motor strip.
Oh, wow.
So you can induce movement by moving across the motor strip, which kind of lends itself to the idea that we are going to find other uses for this as we determine other areas of the brain that we can impact. One of the limitations is how far you can go into the cortex, so which areas you can stimulate. But there's a lot of potential, and we're excited to enter into that.
We need to move on, but one word about suicide. So anything that you've just discussed related specifically to suicide?
Well, I think related in the fact that severe depression obviously is a very high risk of suicide, and that's one of the roles of ECT. ECT works quickly. It has 80 to 90% effectiveness based on which study you look at. But it's one of the factors when we have a highly suicidal patient. One of the things that we would consider is, with severe depression, get them into ECT, try to get an effective change as quickly as possible.
Right, it's a non-pharmaceutical way of treating depression, and it's more effective than...
It is more effective.
Wow. When someone attempts suicide, it may be a cry for help, that they are discovered by family and friends before they die. However, there are times when the desire is to have the final release from the illness that is tormenting them to the point of self-destruction.
She suffered quite a bit from anxiety and would talk about like anxiety attacks. She started seeing a psychiatrist when I was young, probably, I don't know, elementary school or so, and it really wasn't an issue. We didn't know too much about it other than she went to go see this doctor, and it was just therapy. So it wasn't anything we knew to be serious until I was a freshman in high school. She was in and out of hospitals, you know, gone to see her in psychiatric wards, different treatment programs. She had electroshock therapy at one point, which was pretty disturbing because she didn't remember that she had kids. My mom's first cousins, they suffered from mental illness. One of them committed suicide when she was younger, so when I was young. So there was always some specter of mental health issues in the family. I was a senior in college. It was 1983. It was just your normal college weekend, and the phone rang, and it was my dad, and he said, you know, he said, you know, Mom died, and I just, you know, and I was like, what happened? And then he said, you know, she killed herself. We were living in a high-rise condominium, and she jumped out the window. We were on the 14th floor. I mean, 1 second your life is going along, and then the next second it just totally turns upside down and inside out. And I mean, it's just really, really hard to wrap your brain around. And to this day, whenever I hear about another suicide, my heart goes out to them, because I know, you know what those people are about to go through.
Well, that was interesting, and that was a beautiful story, a courageous story, and we appreciate that gift, Amy. These stories are always heartbreaking. People lose somebody, and it's almost twice as bad when it was a suicide. How do you help a family through that?
Well, as you said, it's maybe the most difficult thing that can happen in any of our lives, because it's so hard to understand, and we have such a mixture of emotions. We feel guilt, sadness, anger. You know, it's difficult when someone you love passed away and you have some sense of anger about, you know, why didn't you talk to me? How could you do this to us? But it's also the guilt, you know, I would have done anything. How could you not have come to me? Didn't you know how much I loved you? So all these feelings, you know, create a great deal of turmoil for those left. So, you know, it helps if we understand the situation. A lot of times it is an outcome of an illness.
An illness,
right? A
real illness, like diabetes, you know.
Exactly, and that can be very helpful to talk that through with the family. But we all know loss is hard anyway. So it takes time and it takes understanding, and many people grieve in their own way. But I do think talking about it, just like that's what we would recommend for those with suicidal thoughts. You know, don't be afraid to talk about it. Bring it out.
I had an EMT friend of mine who committed suicide. I mean, he was, you know, I mean, not a closest friend in the world, but a friend, and a good guy, and a fun, happy, easygoing guy, you know. And suddenly he tells everybody it's going to happen, and the next time you're going to see me is in a body bag, sends flowers to family members, and then he's gone. And, you know, I couldn't get out of the anger. I was so mad at him, and I'm still mad at him. And I don't know, I think that anger, you know, that's a big part of what families must feel. And then you feel shame for being angry at somebody who's gone.
Just furthers the conflict that you're dealing with. Yeah, and I think that's the biggest tragedy, but that is one of the reasons, you know, there's probably many reasons, obviously. You mentioned the Judeo-Christian viewpoint, but there's many reasons we try to intervene in suicide. One of them is just the incredible damage that it does leave. I mean, you know, a suicide scars so many lives. And I tell people, as part of my working with them to try to get past the suicidal thoughts, don't try to pretend that this is something that they will grieve and pass on in a year. This is a lifetime impact on those that you leave behind. You know, so, you know, it may sound like I'm working off of guilt, and maybe I am, but you use every tool at your disposal.
Yeah.
So whatever lever you can find, because one of the protective factors is those that you love and thinking about them and thinking about the impact. So, you know, there's risk factors and there's protective factors. So we try to accentuate the protective factors when we're intervening in suicide.
People who are that sad and that depressed are oftentimes focused on themselves only. They can't see the other family members.
Well, and I think one of the hardest things for lay people, let's say, to, you know, to really get a grasp of it is how much depression, the illness, will change your way of thinking, because they're somewhat correct when they say, my brother, sister, loved one, whatever, would never have done that. And they need to end that sentence with, in their right mind. Because I can tell you what, severe major depression, and you've probably seen it, Rick, it's not uncommon that people will hallucinate. So if the mind can get that far with severe depression, right, if you can hear things and see things that don't truly exist, it can definitely change your perception of value. It can definitely make things seem hopeless when they're not. So there is a change in that severe depression that does actually change how that person views the world, views themselves, views their situation.
Well, let's talk about depression itself, because that's the majority of people who commit suicide. I mean, there are people who do it out of spite or out of political reason. I mean, the suicide bomber, and maybe some of those are coerced. If you do this, your family members will get a monetary reward. I mean, that's actually happening over there, I think.
Right. Well,
but the majority is depression, and it is that severe depression. We treat a lot of people with antidepressant medications. They're important armamentarium in a outpatient internist practice. I mean, there are many people who present with anger, and actually it's depression. They present with loss of an ability to function, it's depression. And the antidepressant medicines have been, I think, very, very helpful. Not the full answer. I mean, exercise is important too. But the point I'm getting at is a lot of people don't want to take these. Men in particular don't want to take those medications. And sometimes it's beyond the medicines. So take it from there, Matt.
Well, a couple of key points you talked about. You know, medication can be effective. Often it's not enough on its own. But one of the things we deal with, and as you started the program with talking about the high suicide rate among men, the high completion of suicide. By the way, there's some new terminology about suicide. You mentioned that suicide used to be an illegal act. It used to actually be illegal here in some states, but the terminology, it's a little bit maybe PC, but committed suicide is no longer kind of an accepted term, because it's not committed. It's not as in an act that's, you know, an illegal act. And
so you don't commit suicide anymore.
Right, they complete suicide, and you don't call it a successful suicide. You call it. Anyway, I don't know that that's terribly relevant, but it is interesting. But I think what it is an effort to destigmatize getting help, to destigmatize the idea that you can come and talk about it. And I think when we talk about men that don't want to take antidepressants, what we're talking about is fear of stigma, fear of being labeled, fear of being seen, fear that it's a weakness rather than an illness. So, you know, that's just another hurdle that we have to get over in successful treatment.
What about the idea that the antidepressants that we prescribe might bring on suicide?
Well, there's some validity to that, and particularly if you look at the antidepressants, the FDA has put a black box warning on antidepressants as a class, with the idea that in young adults and adolescents that it can create suicidal ideation. Doesn't say suicide, but
ideas about.
And there's a very small percentage that were identified in the STAR-D study, which was an antidepressant study, multi-center, very, very rigorous, very nice research. Some of it was even traced back to a genetic aspect with a particular medication. So there's a few, there are cases where it will create that. Now that it's a warning, and again, it's hopefully by warning our patients when we start that, they talk about it and let us know, and a different medication can be tried. So it is not a reason to avoid medication. It is not a reason to think that the medications do more harm than good. But it's like any side effect. Be aware of it, report it when it happens, and it probably means that you're going to look at it using a different medication.
You know, they say, and I've heard this a million times, that when a person is so depressed that they're absolutely frozen, they're safer than when they're starting to get better. And when they come out of the hole and they're starting to improve, then they can activate their depression. What do you think of that?
Yeah, I've heard that as well. There may be some truth to it. Well, I mean, when you're severely depressed and you're not eating, sleeping, and getting out of bed, it's hard to end your life.
Yeah.
However, the problem is, and this is much of our problem with suicide prediction, everyone who gets better goes through that phase of better energy. And, so how do you differentiate which one is going to go out and kill themselves? So it's a little bit like saying, if you wake up in the morning, you got a good chance of getting killed. I mean, everybody, it's a part and parcel of the process. So what we lack to some degree is specificity in our suicide risk identification tools. And, there is more research going on in this. There's some interesting research that just came out on a scale being developed in Columbia looking at, there's plenty of suicide assessment scales out there, but what they don't really do well is tell you this person is at greater risk now. They're more static factors. Things like you mentioned earlier, elderly male, recently widowed, those kind of things. But there's thousands of people with those risk factors. So it doesn't narrow you in on who you need to focus on, who you need to put your energy and your resources into.
Well, we can talk about, goes on, it's wonderful, but we need to take a little bit of a turn here for a minute. There are many organizations and groups who try and reach out and help when someone is considered or considering suicide. There are also a number of danger signs when a person is considering this terrible course of action.
Suicide prevention is one of the top issues that we deal with as a campus and also within the counseling center. It's a very strong concern when we're dealing with that population age. They have a high risk of suicide. It is their number 2 cause for death. So we spend a lot of time training staff to be aware of what potential signs are and trying to have them identify at-risk students and get them in for help. Some of the signs that we see are also ones that you would see across the general population, and that would be they may become more withdrawn, depressed. They may start talking about death. They may actually talk about suicide. Not everyone that is thinking about suicide will talk about it, but many of them will. One of the myths that's out there is that the people that talk about suicide don't commit, but they do make attempts. So we do need to listen to that. That is a myth that if people are talking about suicide, that they're not going to. You have a change in their performance level. If they suddenly have much more darker thoughts, or if their thinking gets negative, they start to show signs of hopelessness. They're not talking about the future. Those that have made a plan might actually start to give things away or talk about act like it's the last time that they're going to see you. So there could be a number of just little subtle hints that someone might be thinking about suicide. Then we also have the elderly population that is increased their suicide actions in the last few years, in the last decade or so. There is some differences and some similarities between those. One of the things, for instance, in the teens, you might start to see more drug use or alcohol use. What you might see is more prescription use in the elderly population. that you may see changes in habits and friendships with someone who's a teenager or a college student. With an elderly person, it might be more withdrawal, or they might stop taking care of themselves. They may, stop eating or stop bathing. There may be a number of things that might happen in that way. There may be also just like that social withdrawal that happens in both categories. There may be really a sense of talking about wanting to die with both populations as well. It is a permanent solution to a temporary problem, because whatever they're generally dealing with, whatever stress has overwhelmed them, it is usually a temporary situation. And I think of it as there's a number of factors that have led up to that situation, but it's like at that point their coping skills have become so depleted that they cannot deal with the things that they need to cope with. And so the stress level has gotten so high that the coping skills are just overwhelmed. Well, I think the very first thing that most people are afraid of doing is to actually ask the person, are you thinking about suicide? I see all these signs, is there something going on? Where are you at? Because you're not going to give them the idea. You're not going to create any plan for them. You're really going to offer an opportunity for them to talk. There are some hotlines that are set up, and they have people that are trained to take calls from people, and sometimes they're a listening ear to really just help you get through that moment, that hard time. They also may be somebody who can help get you, make that bridge from where you are to getting some help and finding out what resources are available, so serving as a referral source. So there are a number of hotlines that are out there. There are people, if you have a local, wherever your local mental health center is available, that is somebody who can be there. They have a 24/7 hotline. If you're worried about someone that's not responding to you, one of the things that you can also do is have the police do a welfare check. I mean, you need to make sure that there's good reason for that. But they can go out and they can actually check to make sure that someone is okay. And then they will make that bridge and make that contact so that they can talk with a mental health professional.
I want to remind you of the suicide prevention resources that are available to you. National hotline is 1-800-273-TALK or 273-8255. That is 1-800-273-8255, a national hotline. There's local mental health agencies that are available. There is your local doctor. You can go to your local hospital in the emergency room at any time. You can call the local law enforcement, and they all have help for you. I think it's important that we talk about how do you recognize that there might be suicide in your family. What about that? I mean, when family members really probably feel it coming and start getting worried. Oftentimes.
Oftentimes, and I think the key is to always take that concern seriously. A lot of us probably would prefer to think that it's not going to get to that point, or that it's not that serious. It's one of those things you don't want to regret at your leisure after something's happened. So whenever you hear someone talk of suicide or talk about I won't be here, or some of what you mentioned about your friend, he obviously had these preceding behaviors that were indicative of his suicidal thoughts. The other thing would be the depressive symptoms, isolation, withdrawal, reduced activity, reduced interest, sleeping too much, sleeping too little. Weight loss is probably more indicative of severe depression, although we do talk about weight gain in a few cases. Mm-hmm. So all those signs and symptoms, increased substance use. When you know someone has had an increased stressor and they were already struggling, whether it's work, financial, marital, all those things. And when we talk about kids, a lot of times relationships are so pivotal and so emotional. And we forget as adults how emotionally tormenting relationships can be and how devastating they can be. So we sometimes think of those as just, well, that was a tough crush, or he'll get over that. Mm-hmm. kids can be impulsive, and if you mix substances in with that impulsiveness, that's a dangerous mix.
You know, we were talking, our daughter was struggling with a class, and we were worrying whether she was going to stay at the college that she started at, and is she going to make a switch, and you know, just about before she called us, I think it was a half an hour on the news, here was a suicide of a young college person who was struggling with class and couldn't tell their parents.
Right.
And my wife and I looked at each other, and the phone rang, and we said, "Oh, it's so glad to talk to you. What did you want to talk about?" "Oh, that's whatever you want, dear."
Right.
So I want her to know that, jeepers, you know, we just love her so much, and she is the captain of her own soul, and we're supportive of her, whatever direction she wants to make. And I think parents feel so responsible, but when they get to that age, parents, they're out of your hands. Let them have a loose rein and let them guide their own self.
But you brought up a good point. It's not always the kid that's obviously struggling. Sometimes it's those that are super compulsive, super successful, and all of a sudden they hit failure, and they don't want to share it with their family or their friends or their community. You know, they're the ones that always had these incredible expectations and always, you know, hit the highest mark, and that's devastating to them. And so, you know, it isn't always those that are obviously struggling.
So so here's the take home I want, you know, red flags, this is very important. You can't tell many times, and it's no fault if you didn't pick it out, and it happens. And so don't carry that guilt the rest of your life if you missed it. I mean, here's some clues. If you think there's something, try to get help. Get that person to help. You know, we can call these hotlines. Any other thoughts, Matt?
Well, I think there's some other local resources. 211 line in this area is active, and that's a very good resource.
You just pick it up and go 211?
Yeah, and they have trained suicide volunteers talk about issues. One of the things is exactly what we're talking about. Don't be afraid to ask. Don't be afraid to talk. A lot of times that person is just grateful to be able to get it off of their chest, to begin to talk about the thoughts they've been having. The VA, Janelle Christensen runs a very good suicide task force, suicide intervention team. So there's a lot of resources, as Deb mentioned on the clip. But Avera McKinnon Behavioral Health Center runs a 24/7 phone-in or assessment program. So you can bring someone in.
Anytime, 24/7.
It's 24/7. It's at the Avera McKinnon Behavioral Health Center, which is right off Louise and 229. There's an 800 number, you know, so just...
Don't have to have the phone call at all. Just bring them in. Bring them in.
Yeah.
Get some help. I was thinking about that old guy who lost his wife that committed suicide that I know of, that's sticking in my mind. And I remember our national AMA president made a highlight on that if you know, particularly of a new widower who's lost his wife and has been isolated, maybe even isolated because hearing's not good, you know, has been, you know, out on the farm or somewhere alone too long, make a friend. Spend a little time with him. Make sure that he knows that he's cared about.
You just picked out a trend, though, that's almost like a silent epidemic. I was talking about this with a colleague in preparation for doing the show. One of the things we talked about as psychiatrists, that's exactly the individual that rarely ever comes up on our radar. We don't have a lot of them come into the hospital, and we don't read about a lot of them in the obituaries, because it will say, when I see a 20-year-old that says died at home suddenly,
you know,
my radar goes off. I have a great deal of suspicion. But when you see a 75-year-old gentleman die at home, you think, oh, poor guy must have had a heart attack. Or it's amazing how often it's happening, and statistically we're tracking it through things like CDC or NIMH, but I don't know that in our communities we're even aware. I mean, you're aware when it's someone close to you, but not only are we not doing a great job of preventing that, I don't even think there's the awareness. The statistics are there, but the community awareness is limited and lacking.
But you know what you can do is you can see the obituary of the wife, and you can go, survived by husband, and you go, I know that guy. I think I'll give him a call. I think we're nailing it. That's an important issue. And unfortunately, you know, these people go, well, I want to join her. See ya. Sayonara, folks.
Well, what is the protective factors that keep us going? Work, obligations, and caring about loved ones. And those things just, there isn't a lot of those protective factors left. And sometimes they're in ill health, you know, finances may be, there may be many factors, but it's been that loved one that's kept them here. And that's no longer a protective factor.
Yeah, so that's interesting. Work, loved one, and what was the other one you said, the third?
Well, I said, you know, finance is usually the stressor that tips you, and a lot of these folks are on, but really, I mean, it's, you know, if you go even back to Freud, which I'm not Freudian, but, you know, someone asked him to define what is good mental health, and of course he said it in German, which I can't, but he said, to work and to love. I mean, those are the things, you know, to be productive, if I would simplify it and say to be productive and to have meaningful relationships. Right. Those are what keeps us going.
Have a reason. I've got a reason to do this.
I've got a reason, and I have people that I care about and that care about me. And if you've lost those things, there isn't a lot to keep you rolling. Keep
you thinking that you got a purpose. I think that's the reason why we need to try to, all of us, need to be involved. I mean, you know, there's a million volunteer things that you can do. If you've got this idea, well, I don't have any, boy, just call a volunteer bank. There are so many in Brookings, and I know there's one in almost every community. Is there something, anybody need some help? My gosh, all of a sudden there's a need for you, for all of us. And that handout, that sharing with another person. So many people in need, let's not give up ourselves when we could be giving to others.
You're absolutely right. There's a lot of resources, but most do depend on you as the individual to reach out. We're not, as you suggested, we're not going to that person at high risk and say, hey, come with us. We want to get you involved.
And before we move on, so if I asked you if you thought about committing suicide, would that ever bring on suicide?
No, it does not, and that's an important thing. A lot of people say they're afraid to ask, and you know, that's been looked at in research. It's absolutely a myth. It's one of the best things you can do at the point. If you have concern, ask the question.
Unfortunately, there just isn't a simple procedure to prevent suicide. Depending upon the patient, we may have drugs or counseling that we would prescribe to address a specific problem, but the bigger problem is catching the potential suicide victim before they cross the line. The relationships that a person may just be one of the best lifelines that we can offer.
I was elected to be Bishop of the Diocese of South Dakota on May 10th, 2009. It was a Saturday. That following Tuesday, I attended my first official act, which was a funeral for a young woman, 28-year-old, who had committed suicide up on Standing Rock. She was less than 2 weeks away from graduating from college. You know, that just was a reminder to me of the depth and the complexity of the issues around suicide. Suicide is just a brutal thing to do to those whom you love and leave behind. It's nothing people get over. Your family doesn't get over the death of someone that they've loved and lost. And it's just very important to help young people to know that that is a pain, and it's the pain that will last. It is the pain that will last. And it just does. And so it may seem like people are paying a lot of attention, but once the attention's gone, is all that is left is pain. Cluster suicide, that's a real issue, and to try to get at the effects of that, and I think especially on the reservations, but I've seen it happen when I lived in Pierre. They had a rash of cluster suicides. That's a hard one. It tends to be more prevalent among young people. And part of the challenge is how, when a family is grieving, do you honor the lost loved one without romanticizing the event? And that's a real struggle, and a struggle the church has. And I think the communities and the tribes especially have wrestled with that. One of the ways to get inside of it is through building of relationships. And the church, the Episcopal Church in South Dakota, has just hired our first Native American, full-time Native American youth worker who's working up on Standing Rock. This is a model project that, if it's successful, and we believe in these early stages it will be, we want to replicate on each of the reservations. But it really is about building relationship. We want to build relationships with the young people with their Creator, with God. That's an important spiritual relationship. We're building relationships with the young youth worker and his wife. They're 28 years old, and so they can identify with these young kids, and they're building a relationship with the pastor priest who's on the mission and his wife. They work with these young people, and again, they're building relationships. Elders come in and they help. I really think that to get at the core of it, it's really about helping build the young people's relationships with others around them, with their Creator, and among themselves, so that there is a sense of accountability to each other. This youth worker has two programs going on, one in Wakpala and one in McLaughlin. Over 30 teenagers each week are showing up to this. I mean, it's huge, and these kids really are hungry for someone who cares about them enough to spend really some quality time with them. The real statistic is how these kids are able to see hope over despair, and how they're able to build lives that are worthy of who they are.
Well, that was interesting. It leads me to think about the bullying issue that's happening, and there's a movie coming out about bullying.
Right, you and I were talking about that prior to the show, and I think the movie is called Bully, and it's gotten a lot of press, partly because there's a rating issue, and as I understand it, the producers or whoever created the show wants to get it to a broad audience, but because there's a few inappropriate words in it, it's gotten an R rating, so now it's coming out not rated, which limits the number of theaters it can be in. So
But a lot of kids should be seeing it, don't
well,
they?
I think so. Not having seen it, I mean, you always hesitate to recommend something without having firsthand knowledge. But I think the topic that it is touching on, which is the idea of bullying, and if I understand it right, there's a couple of kids in this that are portrayed or discussed in this movie that commit suicide, at least in part as a result of being bullied.
Do you think that actually happens? I mean, being bullied is a terrible feeling.
Well, and it is a risk factor, certainly for suicidal thought and probably for suicide. Interestingly, the symptoms that lead you to be bullied are also the symptoms that will lead you to suicidal thoughts and suicidal action. So at least some of those cross over.
And you were probably never bullied. I just can't see you being bullied, Matt.
I had a terrible childhood, but
Did you?
We won't. No,
no,
I'm just kidding. But we all saw it. I mean, I will say this, that schools are much more proactive. There's, I know in the Sioux Falls school district there's an anti-bullying program, and they talk, they teach kids about bullying and talk about intervention and talk about the steps to take if you're getting bullying or if you see just a classmate being bullied, so it isn't up to that individual, because oftentimes they are afraid to report it or to make an intervention.
But it never ends. I mean, people bully all their lives. People bully their mates.
Right.
People will bully their employees, in the college system, you see the hierarchy down, and you can see bullying occur. I mean, it never ends. And I think that lessons about bullying would help all of us in this world.
And I think one of the lessons is it's not a harmless part of normal activity. Growing up. It's not normal, and it's not acceptable. And it's not, like you said, it's not a part of the social fabric and the social hierarchy. It does not need to be occurring in our society. So, and it's not harmless.
And it's not harmless. Some say that bullying is really a result of a male who didn't have a parent or a leader, a male who didn't have a male mentor say, our job as men is to protect. Our job is not to bully. Our job is not to threaten. Our job is to protect. And if more of us protected the innocent from the bullies, it would be a good thing.
Well, I think like all behavior, it's probably a very complex issue, probably a very complex answer. And interestingly, again, a lot of those factors that lead you to be bullied also lead to bullying, and it is things like isolation or lack of a compassionate environment when you're growing up, and both bullies and those bullied are at higher risk of suicide. So
the bullies are too.
So clearly, this is not this is not a
conflict.
content, happy, confident group in themselves.
No, you're right.
That is committing the bullying.
Let's move on to the issue of cluster suicidal issues. I know that there has occurred certain towns, in Pierre, for example, for a period of years, there was a number of young high school kids that did it as a group. I mean, one would commit suicide and then another and then another. It was sort of following, and then it happened in the reservations. It's happened in any smaller community. We can see it happen. Why is that? What's the dynamic?
Well, there's kind of two different dynamics, and you just mentioned them. One is the pack type of dynamic, where you have a group of friends and whatever brings them together, but there usually is a discontent aspect to their relationship, and they will make a pact. I'll kill myself if you will, if this happens, or or if I do it, you'll do it, and that's, we have seen some of that. We've seen that, most recently in Minnesota. But then you also mentioned the reservation, and a lot of those, there may be some pacts involved. I'm not cognizant of all the episodes that have occurred, but there's also, this may be not a great term, but the kind of the copycat or almost the role modeling. Well, so that what you fear is that it almost becomes culturally acceptable, that there's a when you've had multiple models, multiple people who've committed suicide.
And in all this wailing and all of the sorrow and all this attention, and all these people are getting the attention, why can't I have that same attention? I know, I'll do it too.
Well, and some of it, and I've talked with Native American youth and adults, and also their beliefs are a little different, and I won't pretend to be an expert on that, and I hope that I don't offend anyone or make a misstatement, but I've heard them say, I wanted to see my auntie or my father, or so I think there's maybe a little bit different concept about the consequences of suicide as well
on the reservation.
But I think what is consistent is these are people under a great deal of stress and duress, and often, as you said earlier, I mean, there's often been previous attempts. But at some point, the action, the thought becomes the action, and when substance abuse is involved, there's often not the opportunity to pull back and say, hey, wait a minute, what am I doing? And
what should a high school do if there was a suicide in the high school and the concern that it might become...
That it might snowball into a copycat? Well, I think high schools have gotten very, very aware of this, and you do see the grief counseling begin, even after, not just a suicide, and I'm pleased to see this, that even after anything, even an accidental death of a youth in a community or a school, you'll often see the counseling begin, the opportunity. If they don't address everyone as a whole, they'll at least open the doors and say, anyone who's struggling, please come in and talk to us. So there's a very, again, kind of a nice set of resources in which the schools have learned to respond to these kind of stresses for their students.
I had a patient, actually it was a high school kid who came to me years ago and was doing an interview with me. Dr. Holm, can I have an interview with you? And the interview was about suicide, and the suicide was from a friend of hers. And the question was very nice, and she had done her research, and there was all this nice question, and then it came down to the bottom reason that she was really sweating this, and this was the hardest thing for her, and that was, do you think that my friend will go to heaven? I didn't know how to answer that, Nat. Do you have an answer for that?
I don't.
I'm putting you on a spot.
Yeah, that's a tough spot. And I'm definitely not qualified to answer that one, and I might be hard-pressed to tell you who is. Clearly there are differences there amongst religious beliefs and amongst cultures. But I think that, for some individuals there is the belief, and it can be another protective factor, as a matter of fact, that if I were to kill myself, I won't
Well, and I think that's the reason that all started really was, don't do this. Whatever we can do to frighten you away from it, or to encourage you not to do this bad choice. It's a temporary deal. Give yourself a month and life will have meaning again. Don't do that. Bad choice. I remember saying to the girl, I couldn't say it. No, I said, we just don't know. We don't know this, but this was a good person. If this was a good person inside and you knew her as a good person, that's what matters in God's eye.
Well, you'd like to believe that that's the case. I mean, if you're a Christian, you believe that all sins can be forgiven. But again, I don't pretend to know that answer. I do know that it is a very difficult issue for many people who are survivors of those who have committed suicide and those contemplating. And sometimes, as you said, in a good way, if it makes them stop and think.
Maybe that's the right thing. I believe it is a moral duty to provide comfort for the suffering. About 20 years ago, my father was dying of metastatic colon cancer spread to bone. Dad was one of those unusual cases in which meds were simply inadequate for his unrelenting pain. Either he was totally unconscious or awake and very uncomfortable. There seemed no helpful in between, and too often pain meds brought wild and scary dreams, caused him to be combative, and frightened him and all of us involved. I should add here, we do better nowadays. Mom called me one evening and warned me that Dad was talking about driving into a bridge abutment. Then she handed him the phone, and I pleaded with him not to do such a thing. I'll talk with your doctor and find a better pain reliever, I said. How do I get relief, and how will this end? He replied. I explained desperately, in cases like this, people often develop pneumonia, and since he directed us not to use antibiotics, this might do it. But don't kill yourself. Indeed, in less than 2 days, he developed pneumonia. His need for pain medicines lessened, and in less than 2 more days, he escaped his cancer, dying from pneumonia. The death certificate called it death by natural causes. But I suspect he voluntarily stopped coughing after our talk that night, which allowed for the blessing of a rapid case of pneumonia. Still, I would agree on the natural cause statement. There are those who request that physicians should, by law, be allowed to prescribe death-inducing poisons for patients who are similarly suffering. These people could then fill the prescription, take the poison on their own time, and thereby choose to die on their own terms instead of having to wait for pneumonia. Although this is law in some states in the U.S., I struggle with that prescription for death. In my opinion, the issue turns around the word intent. It runs against my moral duty to give a poison intended to kill. On the other hand, I consider it also my moral duty to prescribe enough medicine intended to relieve suffering, even if it might hurry death. I believe there's a huge difference between the intent to kill and the intent to comfort. Matt, that's a tough issue. You know, there's a lot of psychological things going on in a family and in that patient when they're dying. Any advice a psychiatrist can give me on that particular topic?
Well, you touched on it. Very few, if any of us, are comfortable with the concept of death. And, you know, I've lost 2 parents, both of which kind of struggled toward the end of life. And it's something I've contemplated a lot, as have brilliant people throughout history, and I don't know the answer to how to deal with that situation in life. You hate to see people suffer, but like you, I've kind of dedicated my life to trying to convince people that life is worth living, that you need to keep fighting and keep going on. So I don't think there's a simple solution, and psychologically, it's going to be hard for us no matter what approach we take.
Well, I want to thank you so much for joining us and your expertise in this tough issue. I think that it's a great joy to have a friend in this field. Thanks so much for joining us, Matt.
I enjoyed it always, Rick. Thank you.
That closes the book for our show on suicide prevention. I sincerely thank our studio guest for visiting with us about this very important topic. Matt Stanley, the Avera Medical Group, University Psychiatry Associates in Sioux Falls. Tiffany DiBartola wrote in How to Kill a Rock Star, no one commits suicide because they want to die. Then why do they do it? Because they want to stop the pain. Until next time, stay healthy out there, people.
Funding for this program is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.